Hi, everybody. Welcome to the April 2026 meeting of the Disability in Medicine Mutual Mentorship Program, or DM3P. My name is Suchi. I am the CEO and Executive Director of DM3P. And tonight's topic is going to be hearing loss in medical training, navigating sudden disability as a medical student. And our guest lecturer is Prachi Gaddam. She's a fourth year medical student at Drexel University College of Medicine. She's currently completing a research fellowship in otolaryngology at Mount Sinai, and she's applying to an otolaryngology residency this year. So good luck. She is a cochlear implant recipient and developed a scholarly and advocacy interest in disability in medicine, specifically as it relates to navigating medical education with sensory losses. And her work includes writing on physician identity and disability, presenting on accessibility in clinical training, and contributing to ongoing research and educational initiatives at improving inclusivity for trainees with disabilities. So, Prachi, welcome, and thank you again for being here. I'm going to turn things over to you now.
Thank you for the warm welcome. Really excited to be here. Thank you all for attending. Really excited to hear your perspectives as well and kind of have a back and forth conversation about everything. I will share my screen. Well, hello everyone. I'm Prachi. I'm a fourth year medical student at Drexel. I'm applying into ENT this year. So, like Suchi said, wish me wish me good luck for that. Going to be presenting about my personal experiences navigating a sudden onset disability in my first year of medical school. I'm still very new to this space, so I'm really excited to also hear about your guys' perspectives and, again, have that sort of back and forth conversation. So, how it began, the story kind of begins in February of 2023. I was in my first year of medical school. I was about 6 months in. You can see the photo there. It's from my white coat ceremony about August 22 that year. 6 months in, I was as bright and wide-eyed as you could probably imagine, although the weight of medical school exams and having to do practicals and this and that did weigh on me a little bit. I took a trip to India to celebrate my cousin's wedding, and excuse me, amongst the fanfare and the everything that was going on, I woke up one morning and I noticed a sort of fullness in my ear. Didn't really think much of it. Indian weddings are very loud, and I was just on a plane for about 24 hours, so I thought maybe it was a case of, some station tube dysfunction or a noise-induced something. So, I was kind of waiting for it to get better over time, and I quickly realized that I was talking to people and I was only maybe getting half of what people were saying. I was really focusing on, reading lips, and I was looking at people a lot more and really just struggling to understand what was going on. I was no stranger to ear infections as a child, so, that was on my differential as well. I was like, maybe this is just a really weird case of otitis media, and it'll all get better with, a prescription of Augmentin antibiotics, and we could all call it a day. So I ended up going to a doctor in India who, did one scope inside my ear and was like, everything looks fine, your eardrum's perfect. Go forth and have fun at this wedding and try not to think too much about it. And I'm sure many of us have had experiences with doctors who are just kind of like, whatever, it's all in your head, you're fine. Take an Allegra and hope for the best. So I knew deep down that this was something more than that, but the wedding stopped for no one, and I resumed partying to the best of my ability. When I got back to the States, I immediately had to take a cardiopulmonary exam that I had missed while I was abroad. So slowly deep dive into the medical school of it and just try to keep my head above water. When I still couldn't really hear my classmates and I was struggling in gross anatomy lab, everyone's wearing masks and formaldehyde smell is there, and I was really like, oh my God, something's going on here. I finally decided to go to the ENT in America. And when I did, that's when I received my diagnosis of a profound hearing loss. You can see on the right, this is my real audiogram. So once again, HIPAA compliant, I suppose the Zoom will be. But you can see that, um, it wasn't looking good for me. The boxes all the way on the bottom with the X's represent the left side hearing, and you can see that I had to have the sound very high up for me to be able to hear it. And this was a profound hearing loss. Hmm. So I know a lot of you are probably asking like how could this have happened? And that is a really good question that I think to this day I've been asking myself because you know, it happened so suddenly, almost overnight, basically overnight actually. And I think with the amount of time it took me to finally sit in the audiologist chair, it had progressed to a level that was very severe. At the time, I saw a physician who, was once again very dismissive. I'm not sure if that was a recurring theme for many people, but for me, it was at least in the beginning of my journey with this illness. But he basically was like, "Hey, at least it's only one ear. You have the other one, right?" So it was kind of the start of, feeling very dismissed by the medical profession, which I think caused a lot of turmoil in me because, here I was day by day learning how to be a good doctor and how to talk to your patients. And we go through all these standardized patient protocols. And if any of you are in medical school or have been in medical school, you know what that's like. You walk into the room and you're given a scenario of how to talk to a patient, how to deliver bad news. And it was like this guy did like the exact opposite of everything you're supposed to do. Super dismissive. And it wasn't until I disclosed my status as a medical student and I knew I was 6 months in, I knew nothing. It was really, really early on in my training. But I think just the fact that I had disclosed that, he had finally started to take me just a slight more bit seriously. And, when I pushed for the MRI and I pushed for further testing, that's when he acquiesced and was like, all right, fine, you can have whatever test you want. Like, good luck with that. I'm not really sure what you're gonna get out of this. So I think that was like kind of the first exposure I had to what it's really like being a patient in the system as well, which if it sounds naive, it really was. Up until that point, I was fortunate enough to not really need a lot of medical intervention, and suddenly I was thrust into a world of doctor's appointments and injections into my eardrum and steroid prescriptions and this and that. And it was really jarring. And I think my primary thought was, oh my God, why is this happening to me? I, excuse me, later on, I quickly realized that this is actually a reality for a lot of people. Most disabilities are acquired, and, it's a reality that a lot of my patients are going to face in the future, that a lot of us as physicians will face in the future for whatever reason. It's um, not as uncommon as I think my 23-year-old self thought it was at the time. So it's interesting. I've come a long way since then in my perspectives, but I think that was kind of the first time I had experienced that sort of immediate, like I'm suddenly being treated in a way that I would hope to never treat one of my patients. So a little bit of how it started, I realized very quickly that my hearing wasn't going to come back despite all the interventions we did. And I had to immediately go from there and figure out what was going on. There were a couple of testing things that we had to do in the middle to figure out if it was a tumor or something else we needed to investigate more. This was the time when I reached out to my medical school. So into this diagnosis of idiopathic sudden sensory neural hearing loss and knowing that I was going to face a lot more struggles in school and in the clinical environment, I decided it was finally time to reach out. So I called my student affairs dean, Dr. Ellen, who was wonderful and immediately kind of connected me to the necessary departments. She connected me to the Office of Disability Resources, who were it's an interesting relationship that I had with them, and I'll dive more into it when I talk a little bit more about my barriers and the accommodations that I received. But that's kind of all where it began, and this was February of my first year of med school. So a little further on to the timeline, I made the decision to get a cochlear implant. This was not a decision that I took lightly, and little heads up, cochlear implant surgery remains controversial in a lot of communities, and everyone's experience is different. I personally decided that I would get the implant. I grew up hearing, and I, realized that I needed the implant and wanted the implant in order to make my life easier. But that being said, getting the implant is a very personal choice, and people have different takes on it. So I just wanted to preface before I said anything else about my experiences with it. In case you aren't familiar, the implant works in the following way. There is a external sound processor and a microphone, excuse me, that picks up the sound and then transmits it to an internal magnet and receiver. That magnet underneath the scalp is actually connected to an electrode array that is threaded through the cochlea, which is the hearing organ. And the cochlea is usually what is damaged in situations where you would need a cochlear implant. So the electrode array functions as a sort of makeshift cochlea. It transmits electrical signals into your auditory nerve, which is usually functional in situations like this. And then that auditory nerve sends that information to your brain, which interprets the signals as sound. So it sounds really cool, and it is really cool, but it's definitely not as simple as what I just described. The sound that you experience when you first get an implant, it sounds like beeping. So think like beep, 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 a truck backing up. Excuse me. And then as the weeks go on and you adjust and you start retraining your brain how to hear, I describe it as like a really tinny, almost Alvin and the Chipmunks kind of voice. If you ever watched the movie, I don't know if that's a dated reference, but a lot of patients describe it like that. And with time and with practice, specifically training your ear how to hear again through directly streaming content into your cochlear implant, it's really cool. There's like a Bluetooth feature. It's on iPhones, Androids, whatever, and I would stream the information into my implant, and I would basically teach myself how to hear again. So I got this surgery right before I started my third year clerkships. So throughout my clerkships, that's basically what I was doing. I was in the daytime learning the new vocabulary of medicine and rounds and how to present to an attending that wants the information in 2 minutes. And then in the evenings, I was listening to children's rhymes with this one implant ear. And I would stream and I would, basically teach myself how to hear again. And it was a really weird dichotomy of a situation, learning so much content in the day and then kind of learning things that are very simple in the evening. And, you know, dealing with that was definitely something. And it's hard to think about it now in retrospect and be like, oh yeah, yeah, I did that. But in the moment, it was definitely an interesting experience to say the least. That is a photo of me right after I got my surgery. I was on pain meds at the time, so I actually do not recall taking this picture. But um, yeah, I had a lot of hope. I think when I got my implant, the day that I got activated and I could hear a little bit of noise in it, I'm pretty sure I like cried since the first time since my diagnosis because I was like, wow, this is great. I'm hearing again. And I think, you kind of sober up a little when you realize, oh, like it takes a lot more work to actually be able to process speech again and to feel comfortable enough to go out into a really noisy, crowded place and be able to hear. And that was one of the things, right? Is like when you lose your hearing, like especially in such a sudden way, I think it was really jarring for me to go from being able to go out on a Friday night and sit in a really crowded restaurant and be able to engage in conversation with very little exhaustion to now every social interaction is like, oh my God, this is exhausting. I'm cognitively fatigued and I really have to look at people and I feel like I'm staring at people too much and I'm reading their lips and it's really hard and it becomes even harder when you're in an environment like the operating room where there's masks on, which I'll talk a little bit more about. But yeah, that's kind of why I made the decision to get the implant and a little bit more about how my experience went with that. Obviously, super personal decision, and I have little regrets about it, but I know that that experiences changes depends on a lot of factors, and it's not a one size fits all solution for any situation. So navigating the system, kind of the crux of this presentation is, so that happened. It is what it is, and I, got the surgery to help me navigate this world, but not as simple as one would assume. Some of the barriers, I talked a little bit about it, but the operating room was probably my biggest barrier. Mask-dependent communication. It's loud in there. It's a high stakes, high risk kind of scenario where rapid communication is very vital, and you don't want to miss things. But I was missing things, right? Like I remember my first case in surgery. I was navigating the abdomen with a camera for a laparoscopic procedure of the belly, and I was kind of absorbed in what was going on, and maybe I wasn't really looking at the surgeon or paying attention quite as much as I could have in the moment. And he suddenly was like, "Are you not listening to me? Like, are you deaf or something?" And I remember feeling so shocked, being like, actually, I have a cochlear implant. Like, can you please speak louder, or use my name or something to get my attention and, help out?" And surprisingly, I think that worked really well, as just being direct and, telling them what I needed in the moment. And that was kind of how I got through it. But yeah, that was a barrier for me, was just being in the operating room. Emergency department, similar situations, very fast paced. There's multiple overlapping conversations, there's noise, it's a cacophony of communication and sound. So it was obviously very difficult to be in that environment as well. Educational settings, this was more towards my first and second year, large lecture halls where you're communicating with people. The gross anatomy lab, also, masked up. It's hard to hear people in a similar environment as the operating room. Um, and yeah, it was hard to, obviously, like, real-time captioning in clinical context is not always feasible nor, possible. So I think that was really big. I could in lectures obviously get captioning, and my medical school was able to accommodate, but it became a lot more difficult in my third year for that to be the case. So now coming to the accommodations, what went right? I talked about it a little bit when I was telling you my personal narrative. Early institutional support was a big part of it. I proactively reached out and I got connected with student affairs, and they kind of immediately knew what the pathway was to get me connected with the Office of Disability Resources. So that was very clear and very well organized, and I commend Drexel for having that sort of request form and being able to set up a meeting with them and figure things out. I think the challenge here was that I didn't really know what I needed, and perhaps some of you can relate to this if you did have a sudden onset disability. Is you're kind of thrust into this world where people are sometimes willing to help, but you yourself don't know what you need. And I think that's where I really struggled, was even figuring out what I could ask for, what I needed, where I would struggle. Like, I don't know, got my diagnosis, and 2 seconds later they were like, what can we help you with? And I was like, I don't know. Like, I don't know how to figure things out and who to ask, and and really how to go from there. So I think that was a good thing, was being able to get connected, and obviously the process after was a little bit more complicated than that. Learning infrastructure, that was really important. So reliable closed captioning for lectures was really a plus, and something that existed for all students universally. And I think that was something that, a lot of medical schools adopted during COVID, when Zoom lectures became more of a thing. And I would hope that that's something that is continuing, because I think that benefits all students to have transcripts and be able to look back and figure out what was going on during the lecture, because it can be really hard to hear for a lot of people, not just, people with documented hearing loss. Flexibility with medical appointments was a really big one. And I think another area where Drexel really went right was being able to request medical appointments without needing to go through an extensive process, or, fall to my knees being like, please, can I go to said audiology appointment or whatever else. So I think the way they did it was through a streamlined absence request application, like mobile application on the phone, called Do Compass. Not sure if other medical schools have it as well, but I think that was something that was really helpful, was, being able to send that in whenever I needed to leave for an appointment, or if I wasn't feeling well or something was going on. I think just being able to do that really helped, and, being able to immediately connect with any professors or, excuse me, staff, and figure out what work I needed to make up, and having a system that was already established and in place was really helpful. This is one that might also be unique to Drexel, but Drexel does not have a flagship hospital since we lost Hahnemann. So we we're a school that did something very similar to what a lot of DO schools do, is we send our students to different hospitals for each of their rotations. That being said, there was room in the schedule and in the rotation planning for some students to have one regional campus for the entire year of their clerkship, so that every single clerkship would just be at one hospital. So, with my accommodation verifications letter that I had my doctor fill out and say that I needed to be in one place to access my medical care, I was able to be guaranteed placement at a regional campus. And I think that really helped a lot too, and something that I would highly recommend to any student who is about to enter clerkships and is in a similar situation where rotations may not be all in one place per the system, is to advocate, and hopefully someone will advocate for you to be in one place if possible, so that you are able to access your care, and that's just one less thing that you have to think of. Because I know I was having semi-monthly like audiology appointments and speech language pathology appointments and this and that. So it was really helpful to be able to be in one place for the duration of my third year. Another thing that was really helpful was flexibility during transitions, and I urge all of you to be proactive about this, and hopefully your school is equally as supportive and being able to work around any surgery times, recovery times, if you do have medical appointments, and figure out when you need to take step one, when you need to take step two, how can you adjust your clerkships to be able to accommodate any sort of medical care that you might need to receive. I mentioned briefly earlier that I took step right before I got my cochlear implant surgery. But before I made that decision, there was actually a lot of back and forth with my medical school about when would be the right time to get my surgery in relation to my step one preparation. And I think it was that sort of back and forth, which was really helpful because, I was fortunate in that my cochlear implant surgery is not an urgent procedure. I had the choice of when I could have my surgery. And so for anybody who, is wanting to go some sort of elective procedure to make their um, illness or condition better, I would say having those conversations early on with the academic team is very helpful. And we finally decided that I would first take step and then have surgery, and then complete a remote clerkship right after surgery to account for any post-operative recovery that I might need. Cochlear implant surgery is kind of a mixed bag. Some people do really well and they are immediately fine and up and at 'em and can run a marathon. And then some people have some pretty severe post-operative dizziness and nausea that can last a couple of weeks. So I wanted to account for that and make sure that I wasn't taking a big exam right after that, nor was I immediately jumping into a surgery or obstetrics and gynecology rotation that would have been very demanding on the body. So I think that sort of communication early on was really helpful, and honestly, it was very proactive on the part of my student affairs deans to be able to have those conversations with me and figure out what was best for my situation. What could have been better? Obviously, things went right, but also some things definitely could have been done better for me and could have been made more smoothly. And I think there was a lot of learning, a big learning curve here, and a lot of lessons to be learned in general. One of the things was the continuity of support was a little fragmented. I lost connection with the Office of Disability Resources during my third year clerkships. They were very present during my first and second year, when we were talking about step one scheduling and captioning and medical appointments. But then due to a lot of turnover issues in the department and the fact that the Office of Disability Resources at Drexel did not have a dedicated office and professional at the medical school level. So basically, the undergraduate division was handling all the graduate school stuff too, with the student affairs deans as liaisons for anything that was specific to graduate medical education. So that was a little bit of an issue, not have a dedicated professional that was able to help and kind of understand exactly what challenges and barriers would be going on during clerkships, which is a very unique experience compared to undergraduate education. It's not like a lot of majors in college are having to go to the hospital and rotate in different departments. And, I think having a dedicated professional at that level would have been really helpful. And I would have felt a lot more supported during my clerkships if I had somebody to go to, and if I had somebody who was very, very knowledgeable on what it would be like to, for example, be in the OR, and if there were other students who had similar sensory accommodations that they needed, I think that would have been really great. So kind of leading right into that is I had to rely a lot on self-advocacy, and I'm sure a lot of people in the Zoom might be able to relate to that, where excuse me, you had to kind of read the room and figure out who was like a safe person to be able to disclose your disability to and tell, and who wouldn't, use that against you, or if there would be any repercussions, or you didn't want people to look at you differently or treat you differently. So I think that placed a lot of pressure on me. I think I would arrive to every surgery in my surgery rotation and be like, all right, I gotta like really, really muster up the courage to tell the resident or tell the attending, and I have to introduce myself to the OR staff, and I have to let them know, because last thing I'd want is for them to find out missed procedure like they did in my first case, and have that kind of be a tiff in the case. So I think that was tough. And I think the way to have prevented that, or at least mitigated some of the stress that it caused me, was to have proactive planning before each rotation. So I think meeting with the clerkship director beforehand, like, the director of OBGYN or pediatrics or what have you, and having a proactive conversation to say, hey, this is what my life is like, and this is how I struggle in certain situations. How can we help me do better? Like, how could we accommodate my situation? What barriers do you foresee for me, knowing that this is what I struggle with? And how have you helped other students in the past? Because I think that's also a large part of it, is that chances are you are not the first person who has experienced some sort of issue. A lot of these people have been in their profession for a really long time, and the number of students who have disabilities in medicine is thankfully only increasing as, people get more involved, and technical standards in medical schools are um, realizing that, students with disabilities need to be accommodated, not excluded in medicine. So I think that would have been really helpful, is having those discussions really early on, and having accommodations that were built into the curriculum for me, instead of reactive or after the fact when I realized that this was something I struggled with. So that kind of sums up how things could have gotten better. Obviously, huge learning curve for everyone involved, and I hold no blame. It's all just, ways that things could have gone better. So I'd love to kind of open up the floor to a discussion. I'm also, again, like I mentioned, pretty new to this. It's been in 2023, so I guess we're in 26 now. So 3 years since I've undergone this journey, and I'm learning every day. And with every day comes a new sort of issue that I hadn't foreseen, or, a new thing that I've learned from something. So would love to hear what y'all's takes are on things. If there's anyone who's willing to share, if they, ever needed an accommodation, what was the hardest part about asking for it? Something that a staff member, faculty member, resident, someone that helped your situation, and something that maybe was intended to help but did the opposite. And then we'd love to hear how everyone decides who is safe to disclose to. I think that's something that I really struggled with, because it's a lot of reading the room and hidden social cues, and being like, all right, like, let me observe your behavior for 2 days to figure out if you're like a good person for me to tell this to, or if you're gonna, you know, if it would be pejorative. So, excuse me, I would love to hear from all of y'all. Oh, I also do see some questions. Sorry, I think I missed these when I was presenting. I have unilateral hearing loss, so just one ear. Uh, First time when CI was activated, did you hear static or white noise? It was, yeah, the electronic beeping. It was really not speech at all until later on. And totally right about communication barriers for everybody. It's not just people who are deaf and hard of hearing. Uh, do I use a digital or amplified stethoscope? Yes, actually. It actually streams directly into my implant, which is also interesting. So it's It's definitely a really cool device.
I could jump in with something if others haven't thought of what to say yet, but I think answering your second question about something that a faculty member or resident did that was meant to help but didn't actually. So, I had a new disability when I was entering the clinics, and it was a kind of rare chronic illness. And I went to my first rotation director. She was on neurology, and I was told to just get my accommodations straight from her. And she said, "Oh, well, if you're having trouble with stamina and that sort of thing," I told her, "I don't know if I'll be able to go into a a hospital environment yet. I was so new to things. I had hoped to get just a clinic-based assignment at first, but I didn't get that." So she said, "Don't worry, we'll just exempt you from your hospital-based experience on this clerkship." And I think it really did help with my symptoms, but I didn't get that experience. And then one day when the shift was supposed to change, I appeared as usual and was told, "Now you're going to the hospital." And I was like, "What? What's going on?" And I had been assigned to the NICU as somebody who was untested and untried because the clerkship director was out of town, and her co-director who was in her place was like, this is unacceptable. You have to do the hospital experience." And so without any warning, I just arrived one day to find that I had been reassigned. So it was intended to be helpful, that accommodation, but it ended up backfiring, and I wasn't put in an environment that actually would have been conducive for me. No adjustments were made, and I got really sick. And then, like, it ended up precipitating my very long leave of absence. So that is kind of one experience. I think what would have helped better was just some pre-planning, just like you said, Prachi. Um, and more integration with the disability office rather than just the medical school not being knowledgeable about accommodations, but trying to do their best without that guidance.
Yeah, that makes a lot of sense. And I think that was the predominating experience is like a lot of people think it's like a black and white, like either you just don't do the whole rotation at all, or you have to do it with no accommodations and nothing, and you just kind of go for it. So yeah, I think that's the difficult part of it, right? Is like a lot of these people aren't necessarily trained or know what you can ask for or what they can offer to you. And I think that's why it's so important to have trained professionals. And I'm really glad that UCLA has a DRP that really works with you guys and makes sure that things are accounted for in that sense, because it can be really hard when they kind of take it upon themselves to propose things that may not actually work out in reality. Also, to address feeling the need to look strong, yeah, I completely relate to that. As somebody who wants to go into a surgical subspecialty, and I'm actually applying ENT, which weirdly enough was something I wanted to do before all this happened. So but I think that's part of it, right? Is like there's such a culture of wanting to seem like you're indestructible and you have to be this sort of superhuman, like nothing is a complaint and everything is hunky dory. And in reality, like a lot of people struggle, and it's okay, and it's not like you have to, you know, not get what you need and what you deserve because you're afraid of being perceived that way, but oftentimes it's definitely a real fear. And that's something that I'm still actually struggling with is, again, figuring out in those surgical spaces like how to request these things, what's the right way to say things, and how do you frame it in a way that doesn't hurt you and hurt your grades and hurt your prospects in the field if that's what you're trying to go into. So yeah, definitely a learning process, and it is really tricky. In primary care spaces, just in my experience as well, tend to be more accommodating and more nurturing environment in some ways.
I can read what put for folks where that might be helpful. I said, asking for accommodations is sometimes tricky for me as I navigate spaces. In primary care spaces, I can ask for accommodations without hesitation, but in surgery spaces, it's hard for me to request these given the culture of hyper able-bodiedness that I occasionally feel a need to look strong without accommodations. Um, yeah, and I feel like that's something that we hear a lot with people too. Or like I was more recently hearing from people a sort of sense that classmates resented the accommodations they got or didn't feel it was like fair. And that was when there was a authentically difficult situation that wasn't great for anybody. But it was like the accommodations given were so necessary for the people who got them. And I almost feel like that's true for so much of medicine because it's kind of a disabling space no matter who you are, which is not to discount how different it is for people with disabilities and chronic illness. I'm just saying it wears you down. And so I'm trying to think about what I'm saying exactly, but like everybody in some ways would benefit from some kind of accommodation or understanding or like, you know, just more space to be, whatever that means. And so I just think that that is a hard part of asking for accommodations sometimes. Um, I don't know if that makes sense or resonates with people, but
Audience comment. Medicine and the world values physicality. I was born with cerebral palsy. I don't have to luxury to disclose my disability or not due to the way I walk. I don't practice medicine with my legs. I don't do a lumbar puncture with my feet. It's ridiculous. The thing I don't like about primary care is that you have to see a new patient every 10 to 15 minutes. And at the end of the day, you have to spend hours doing 30 to 60 charts. And to me, that's just as taxing as the computer work bothers my neck. Medicine is very physical. My parents even think if you can't walk, you can't work. And I have to say, what? You shouldn't be saying that. And why do you think that? I don't know how to change the culture. I had some worries, but the surgeons had a lot of respect for how much I wanted to be there and how much I wanted to learn. You might just have to find the right technician that's going to help you out. What I've found is it's all about the individual people who recognize your value.
I think it's a really good point is that people kind of make assumptions about what is hard for you and what is not hard for you. And it takes a lot to chat about the unconscious biases that people have. And it's like, well, you weren't even worried about like, you were worried about charting, like which is a very like everybody is worried about that kind of thing. It's not like something unique to your situation either. So I think that is a big part of it too, is a lot of people just don't know how to give people what they really are asking for and instead kind of choose to interpret the situation, interpret your needs for you. And I think that was something that I experienced as well with I have a pretty hidden disability because, no one can really tell, and my implant is hidden and this and that, my hair covers it. But when they do see and they do kind of treat me differently or, act like I cannot be suited for a fast-paced environment, it's like, well, I think if you give me the accommodations, I can do just as well. And it's not like I'm asking for something that is, extravagant or anything. If that means that people speak louder, if that means that I am spatially positioned in the OR so I can hear the best, that people are on my more functioning ear side, then, that's something that I think can be reasonable in a lot of situations. I think the part where I struggle is like what does medicine define as reasonable accommodation and what should medicine define as a reasonable accommodation, right? Like I think that's where I'm still trying to figure out like how much can I ask for? What can I ask for? What are people willing to give? And what are people legally obligated to give versus like what is like the right thing to do in the space? And I think that that is like the question that I am continuing to ask.
Audience comment. When I was a medical student, I probably had a good enough balance to stand, but don't think I would ever stand while using a needle. I would swap out a chair for a stool. That's a non negotiable. I earned a reputation of being really good at procedures because I overtrained myself. Because if you don't succeed at it, they're going to immediately discard you. In my last experience, a nurse would help me out and always have a chair for me. Once that nurse was on vacation, and someone had put the chair away as they didn't think it belonged in the room. That could have put me in a sticky situation if they had already sedated the patient. I think it's a matter of getting through training. Once the operating room knows you, they should understand your needs. In training, it's really hard to prove to people that have no idea what it's like living with a disability. I often have families sticking up for me because they see the value. I just wish I didn't have to prove myself to my colleagues.
Yeah, that's also interesting that you say it's mostly during training where you have to like prove yourself because I think that's part of the culture of medicine, right? Like, is you have to kind of suck it up until you get to this sort of hill at the top. I don't know. It's been told to me that exists and that, you know, one day you're going to be the person that everyone is going to try to accommodate and everything. But I think leading up to it, like you were saying, like there's so much searching and so much like I'm here and I have to prove myself and I can't ask for help and I have to just let people know that I'm worth it before you get to that point where people are willing to kind of do things your way, which is unfortunate because I think that's not the kind of culture of training that is gonna make for good physicians. And I don't think it's the kind of culture that we should be promoting if we really want people to achieve a level of, you know, success and comfort in their field. But yeah, that's interesting. I'm sorry that happened to you. And you know, I think that's a real big point, right? Is like you have the nurses and you have the techs and you have the support people who are willing to see what you need and make it happen. And then, you know, there's people who aren't so accommodating. And I think that's part of the culture that I really hope changes in the future. Answer your question about bandwidth. Yeah, that was really hard. I think all throughout clerkships, that was kind of my biggest thing was I was doing so much and it felt like I was on my own learning curve in the evenings and in my personal life, and it was really exhausting. I think it was ultimately very rewarding, and I think I'm really glad I put in that time and effort. But yeah, it's hard. It's hard to like study all day and you know get yelled at by your by your attendings in the daytime, and then have to come home and kind of work on something entirely different. I'm really fortunate that I had a really good support system in my personal life that helped me a lot and helped me get through a lot of it. So I think I think that was the reason why I was still able to pursue extracurricular activities and you know research and other things for a residency application. So um, highly recommend a research year too if you're interested in something that is super competitive and you're really burnt out from third year because third year is really draining and it's very draining when you also have to navigate having a chronic illness or disability on top of it. So yeah, I think taking a year if you can financially afford it and if it works out with your life plan, it's a nice way to kind of slow life down for a bit and build in those resume things that you need.
Yeah, I mean, I guess you sort of anticipated where things were naturally going. Yeah, I was wondering like what helped you get through and what in terms of any kind of support system, like maybe that's having great parents or like inheritance that you could like use as a resource to buy, food so you didn't have to cook, or like maybe it's like going home and crying every day in the bathtub. I don't know. Right. I'm throwing out things to like give permission for those to be what it is. But yeah, I'm curious because what that looks like. And it doesn't necessarily have to be medical, but obviously like only what you're comfortable with.
Yeah, good question. I think a big part of it was honestly like the people I surrounded myself with. My family, I think it took them a while to actually even understood what happened, which I mean, fair enough. I mean, I'm still trying to figure out what happened, and the medical aspect of it was like in some ways I felt like I was a good person in a weird way for it to happen to because I think I kind of had an understanding and I was already interested in ENT and yada, 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 great personal statement, whatever. But, I think for my family, it was like, well, what's happening? Like, can't you use a hearing aid? Like, what's going on? Like, is it the cochlear implant just doesn't magically fix things? Like, you're better now. And I think that that was a bit of a struggle, especially in the beginning, but I think they really became one of my biggest supporters throughout the whole process, and I'm really lucky for that. Really good friends during medical school, I think, really helped. And, I think in class when I was having trouble hearing, and they would kind of lean over and whisper it to me or write it down for me, and I think that was really helpful. Like the days when I was out sick or, not feeling up to it or at a medical appointment, I had friends send me their notes and they would tell me what happened during class and what I missed. And I think things like that were probably, the most helpful was just finding people to help me through the banality of the medical school stuff so that I can kind of figure out the personal life stuff on my own. Um, had a really great partner who I actually just married a couple weeks ago. So I think having him was a really, really great part of it as well. And I think just talking to people and sharing my experience. I actually have this on the next slide of like advocacy, and I think that's where I kind of found a lot of my will to go on when it came to things like this because I think there's a medical student urge to always like capitalize on whatever happens to you. And if you can, then you always try to kind of figure out what the next step is. And a lot of us are built that way, and that's how our personalities were. And I think I was very similar in that once I figured out my personal feelings to some extent about what happened, I like immediately wanted to tell other people. I wanted to share my experience. So I went to the AAMC conference in San Antonio this past year, presented my experience there. I presented to my hospital where I did my clerkships and, talked about what I was experiencing and got a lot of feedback from people. And I think that really helped was just finding people who cared about what I cared about and who listened. I think that was really helpful because I think I didn't realize how like starved I was for like human connection about what happened until I got it. Like I was at this conference and someone came up to me and they were like, "Hey, like I have a disability and I've experienced so many similar things and it's not a hearing loss, but it's something else and I'm so nervous about telling my OBGYN residents that this is what I need or whatever." And I think just being able to kind of excuse me, being able to talk to people was really helpful. And I think it made me feel like I was contributing. And I think that was one thing with something like this. Like it happened so suddenly. And I for the longest time I was like, why did this happen to me? Like what did I do to deserve this? And those were kind of the negative thoughts that were flooding my mind, like, oh my God, like did I mess up? Like why did I wait so long to go to the doctor? Like, why did I not go to the doctor before I had to take that exam? Like, why didn't I do better? Why should I should have known better? Like I'm in medical school, I should have known better. I should have figured it out earlier. So I think dealing with those negative feelings, like a big part of that was talking to other people and helping and trying to add a little bit of insight into this really complex world. And I think that made me feel like I quote unquote had more of a purpose with what happened, although that's a very gross oversimplification of it. Um, but it helped me make sense of what happened.
I'm curious what kind of reception you got when you were sharing, like, especially to classmates and stuff, it sounds like, and what that was like.
Good question. I think that a lot of people, interestingly enough, a lot of people thought I was joking, and maybe I just have that kind of personality, I think, where they were like, I don't know. It's also one of those things where, quote unquote, being deaf or having hearing loss is so like colloquial in society. Like we're always like, I'm going deaf or I'm so deaf, sorry, I didn't hear you or whatever. And we kind of drop these terms without thinking about it. So
Yeah.
when I disclosed to, for example, my peer group, during like a lecture hall that we like worked together all year, and I was like, hey guys, like, guess what? Like this happened. They were like, are you joking? Like, is this like a bit that you're doing? Um, so that was kind of like their first reaction. And I think once I like explained what happened in detail and I was like, hey, look, like this is my implant. Like I'm gonna need you to sit on this side of me and I'm gonna need you to speak louder and I'm gonna need you to like do XYZ things for our conversation. And I think once I kind of walked them through exactly what happened and disclosed a lot of those details, then they were like, oh yeah, yeah, that makes perfect sense. But yeah, I think people found it a little hard because it happened so suddenly, and it was just kind of a weird like freak accident type experience that I think other people had a hard time believing it too. And a lot of people honestly responded with a lot of curiosity. They were like, "Oh, like what? Like I guess that's also like a medical student thing, right? It's like you're like, "Oh, like what happened? Like what were your lab results? Like, oh, what was your MRI? Like can I take a look at your MRI? Like what's going on?" So, I think it was helpful in some ways because it made me feel like a little bit like, okay, well, at least people are like, responsive and willing to help me with this, but at the same time, you do feel a little bit like a medical mystery or a curiosity. So it's kind of a mixed bag.
Yeah, I kind of I feel similarly to that. My experience was obviously very different and it wasn't sudden, but I was an MD PhD student. And so my classmates, when they found out what I was going through, they were like, "Oh, you must be having a field day, researching your own illness. It must be so interesting to think about your disease." And I think that was very well-meaning, but it felt very awkward to me because I didn't want to read anything more about my disease. I just wanted it to be gone. And so I was like, well, okay, I'm being sort of given these signals that I don't belong. One of my program directors kept telling me to leave the program. And at the same time, I'm also not thinking like an MD PhD student. I don't have that curiosity about this disease that they all would have if they were in my place. Um, so maybe I'm not really fitting in quite here. Um, so that was kind of interesting. Yeah.
That is interesting how we're kind of expected to kind of function as our own like physicians or function as our own like researchers about whatever weird, crazy stuff happened. And in my case, I that is what I did. And I think in some ways that was kind of like a coping mechanism. Like I guess I was like, well, this terrible thing happened to me, then I gotta prove something of myself, or I have to do something about it, and I have to write about it, and I have to go to conferences about it. And I won't deny that it's like, it's a way that I dealt with it, but I could imagine if you just want to be left alone and you don't want to think about it, like it's jarring for other people to come up to you and act like it's some amazing rare finding or lab value when it's your life. Yeah. Yeah, it's interesting. I feel like the different reactions that people have to when crazy stuff happens to you. Like, I found that especially in the ENT community, they're all like, "Oh, no way! Like, that's cool. Like, I'm sorry that happened to you, but that's so cool that you're like in the OR and you want to do ENT. Like, what a full circle moment." And yeah, I guess in like a perfect like full circle way and like a perfect storybook way, that's awesome, but it doesn't negate the fact that like every day is a struggle and it's hard. Like it's like I have to like muster up the courage every day to like walk into that OR and pray to God that I don't miss something that someone said or I don't mess up and affect somebody because I missed one word or something like that. So I feel like you can like people romanticize it, but it's hard. It's just hard.
Audience comment. I think it's totally fine that you said this, but this is something that I want to change. Why does it have to be terrible? I have only known being seen as disabled. I have never really felt horrible about myself until after my intern year. Due to the culture of medicine not being inclusive, this has affected my self-worth, which is ridiculous. No one is relying on my legs to do any of my work. It wears down your self-esteem and how you feel. I shouldn't have to be afraid every day. I have another chance tomorrow on getting a fellowship position, and I am terrified because what am I going to say? Yet at the same time, I am so tired of having to prove myself, and they're either going to see my value or they're not. In my journey, I have been a physician for over 20 years. One of the first people I met on the interview trial was deaf. I just wish it was more accepted and we didn't have to feel like we don't belong. You realize that the best thing is to say something because you wouldn't want to deal with something happening due to lack of communication, which happens anyway if you're hearing or not. I just wish it was normal that people can be different. And it doesn't have to be a bad thing.
Yeah, no, exactly. Like you just want to not feel that fear every single time, and it's a lot. That's a really good point. To answer the question, do people ever assume that you represent the whole deaf and hard of hearing community? Um, I think sometimes people do. I think because usually the way that I introduce myself to, like, for example, in the OR, a case like that is I say, like, hi, my name's Prachi. I use a cochlear implant. I hear better with my right ear. If you could position things in the OR so that you're on this side, and if you could speak louder and, use my name more often if you need something from me. Those are kind of all the things that I say. And sometimes the follow-up is, oh, like, were you born this way? Like what happened. And, when I tell them my personal details, if, I feel comfortable enough to do that in that space, then they're like, oh, okay, so you're different. You're a single-sided deafness patient. You still have one complete ear. You were a sudden hearing loss patient. You kind of lost it overnight in like a freak accident. And so, you're different. So I think once people hear my story, I think they kind of make an automatic assumption that I do not represent the whole community. And I think I'm very grateful for that because I don't. And my experience is so different. And there's a lot of nuance to this discussion, which is why, I even talked about like the cochlear implant thing in the beginning, because a lot of people in the deaf community, don't really agree with cochlear implants or wouldn't get one themselves or have cochlear implants for any children who have a similar condition. So I think I think if it ever did happen to me, I think I would make that very clear in the beginning that I am just one person who is experiencing something that I am also still trying to navigate, and I will never say like everybody needs to get a cochlear implant or everybody needs to do X, Y, Z, because I think it really is like such a spectrum, and everyone's situation is just so unique and so different to them. I I will never try to speak for the whole community because I am a very new member and I really can only speak to my experience.
Audience comment and question. I think we just have to go back to thinking that everybody is different. Not just thinking every disability is different, but everyone is different. I have a question out of curiosity. My first time in fellowship, my co-fellow was born with one ear. He made a comment once that he hears better on the side where he had his ear, yet it never really came up again. Do you think that he is different due to the fact that he only ever knew hearing from one side, making him advocate for himself less or adapts differently?
Yeah, that's a really good question. I guess if my life was just always like this and this was my normal and this was just like how I functioned, I think I would have a very different perspective. Um, but I think I know what my baseline was like before what happened, and I think oftentimes I'm thinking, okay, I'm never going to be at that baseline, and therefore I have to declare things beforehand, and I kind of have to be super proactive, and I have to tell people, and I have to make sure that it's not like an issue. And I don't know. I'm not exactly sure.
Audience comment. Going from hearing from both ears to only one would make one feel that you cannot function as well, especially if you're still having a hard time. As long as you were on the side that he can hear, it was okay. But I can see why it is different when losing hearing in one ear later in life.
Yeah, I think so. I think it's also interesting because I am relatively young and well, yeah, I'm pretty young, but I think, for individuals who have sudden hearing loss like I did, they tend to be older. And I've seen research on it and also heard anecdotally from, the team that does a lot of these cochlear implants for patients who experience a sudden hearing loss. And, the later on in life and the more time you have with binaural hearing and both ears, it can be really difficult to lose one because your your neuroplasticity levels and different things like that can really impact how you do with your cochlear implant and how you function and how your baseline is and speech perception and things like that. So it's so different. I think maybe in 20 years from now and 30 years from now, maybe I won't even notice. Maybe it'll be like second nature for me. And I am very curious to see how that plays out because at least 3 years in, life has gotten easier than it was 3 years ago. That's for sure. But I'm also curious if I would, you know, still describe myself as really struggling in like 50 years. If I've lived most of my life like this, maybe it just becomes my new normal.
Audience comment. Have they told you how a cochlear implant helps with aging? My dad can't hear well anymore, yet he refuses to get hearing aids. I don't know why, but my mom's like, yeah, he's not gonna get it. And I think it's ridiculous. He says, what? To everything I say. If you were to lose your hearing in your other ear 50 years from now, how would that impact you?
Yeah, no, that's a really good question and something I've also like thought about a lot myself. My mom actually, before any of this happened, like in her like early 30s, was diagnosed with hearing loss, bilateral hearing loss, both ears, like a progressive sort. So, growing up, I always thought, okay, well, if this is some genetic thing, and if I get what my mom has, then yeah, I'll probably also progressively lose hearing in both ears, and that might be a reality that I have to prepare myself for. Um, so I'm also curious, like if that genetic component of my life still exists and is still a factor, then it's very possible, like you said, like in like 50 years, like that aspect of it is also going to play a role. And I also wonder, like, would I be an early adopter? Like, would I get the hearing aid as soon as I start noticing? And I think I can safely say now that that is a yes, because I think I understand the benefit that hearing has in my life, and I think for older people, because it's pretty common actually in ENT, and I've seen it myself, where older people kind of will deny that they have a hearing loss problem for a multitude of reasons, feeling like embarrassed, or they live their whole life one way, and it's like a big adjustment and big change, and human beings at any age don't really react well to big changes. So I think that plays a really big role, but I think I would be an early adopter if that happened. I think I would see it as a way to communicate better and add to my life. And yeah, if that happened, then hopefully I would. I have some new questions, kind of talking about the culture of medicine in general. And I'm actually really curious if anyone's willing to kind of speak on what their institutions have done in the past that were helpful, harmful, what we can do better. Um, I know a lot of us feel very strongly about mentorship and advocacy, so I'm wondering, like, if maybe you do things for your students, if you have medical students that mentor, if there's something that you do, and if people have come to you kind of with their similar struggles and similar barriers, and how you kind of make it easier for other people.
Audience comment. We don't stand for the majority of rounds because there is no reason to. Running the numbers, I always do all of that sitting. Very rarely did people say they want to stand. One student even said that they liked sitting so much better as they have POTS and would pretend to tie their shoes in order to not pass out during rounds. But they're too afraid to say something. This is all ridiculous. I just want to get rid of the physical stamina of it because that's not really medicine.
Yeah, no, for sure.
Audience comment. I was never going to be a surgeon, but people tell me that a lot of surgeons sit all the time. I do think it gets easier once you get to be the boss.
Yeah, that makes a lot of sense. I'm glad that the student felt comfortable sharing that with you, and at least, she got to sit on your rounds, which I agree. Everyone would prefer to sit on rounds, I think, genuinely. Um, yeah, I found that being really matter of fact really helped with people, if any medical students are here as well. And like, I think, anytime I walked into the OR and I was like, I have this and I need this, they would just be like, okay, and I think that might help in some situations, might not. It's really like a depends on the other person, but I'm hoping for a medical culture. That's what I hope for, is a culture where you can just walk into a room and say, I need this in order to function, and I need this in order to be the best student or physician or whatever. And people are like, okay, that sounds good. We'll make it happen. And I think that's probably the best case scenario, so people don't have to hide their conditions, or cause themselves a lot of like stress and anxiety trying to figure out how to have these conversations. Also, I see that talking about UCLA. Yeah, I'm really glad that you have that DRP. I think having that integrated into the medical school level is really helpful, and they can speak on a lot of topics that I think at the undergraduate level or at the general university level is not as as relevant. I'm glad that the UCLA surgery culture has improved. It's funny that you mentioned like Grey's Anatomy. Yeah, I'm hoping nothing is like that in real life because that is really something else. It is interesting that the surgery clerkship you were mentioning that the surgery clerkship chair says surgeons are really afraid of getting reported for mistreatment, so they improve their behavior. That's just really interesting to me that it has to be like a consequence in order for them to, kind of treat everybody as human beings. But yeah, I guess that's a big part of it, right? Is like they don't want to be flagged for poor behavior, and eventually, I guess it becomes second nature to just be more inclusive and mindful. Yeah, it's interesting. You say that they told you that neurosurgery is not a good fit based on speculative concerns. Yeah, that's also interesting, right? Like it's like they foresee things about you and they say things like preemptively and they don't even give you a chance to kind of, excuse me, modify their belief of you. And I think that's definitely part of the culture that I wish could change is like people not already going in with expectations of what you can or cannot do.
Audience comment. In general, they need to stop having low expectations of anyone.
Yeah, I would add that um that there is this emphasis on trying to eliminate the humanity from the physician because they don't have time to be human. And it's kind of a model that I think began as really well meaning, perhaps. I don't know the history, but the intent was to serve. Intent often is to serve and to help people, but it's taken to an extreme where everybody else needs help, so you forget your own humanity. And if we built back in systems that account for the real medical, personal, social, emotional needs of healthcare providers and made that inbuilt into the system, I think things would really improve. I feel like from the little I understand in science and in research, there's this distinction between what's known as positivism and being totally objective, and the so-called squishier sciences where we're constantly thinking about how we are positioned within our studies. And medicine is very positivist and they forget that they are part of the system. Um, it's not just something that you objectively observe from afar, and it's not just a system of components that you reduce. Um, and so I feel like I have hope for the future because I'm seeing more acknowledgement of the things that make us all human creeping into at least being acknowledged by medical systems. The fact that social determinants are being discussed in medical school classrooms and sometimes even in clinical environments where it was maybe only nodded to in the past when I was in training like 12 years ago or so. I think that's a hopeful sign. I haven't seen people incorporate that attitude towards themselves yet, but medicine is slow. We can't expect it to happen overnight, but I do think that movements like this and what you're doing, Prachi, is so important because it does remind people that physicians, nurses, and other healthcare providers really are people, and we should account for the people behind it.
Really well said. Yeah, totally agree. What is the quote? It's like physician heal thyself, right? Like I think that is something that is often forgotten in medicine. And I read a really great piece from a physician who was front lines during the pandemic, and she had lost her father during the pandemic, and she was also working as a frontline worker at the time. So it was hard. Like she had to turn up every day and still do what she had to do while also grieving a loss. And I think for a lot of people, like a lot of physicians are humans and a lot of disabilities are acquired. And whether we all like it or not, like we are going to face some sort of medical issue in the future. And you're right. Like I think there's a lot of times we try to separate the medicine from us. And, they say the physicians are the worst patients and that they don't like going to the doctor and not very adherent to, diet and exercise and other things. And I think it's because we really just don't take care of ourselves very well. And I think it takes a lot of compassion. And it was honestly really hard for me. I would say like I struggled, and especially right after it happened, and it was like such a sudden change, and I was slipping a little. I think I did a little bit worse on one of my exams, and I crashed out. I was like, oh my God, like it's already happening. Like I'm gonna fail out. It's gonna be so bad. Like I'm struggling. And I had this sort of doomsday mentality where I was like, you have to be the best. Like even if this happened to you, you have to do amazing and you have to prove yourself and you have to go cure deafness for everybody if you want to make this thing like meaningful or impactful. And I didn't need to do any of that, right? Like I was like a human being who just experienced like a form of grief and a form of loss. And I really should have had a lot more empathy for myself, the same way I would have had empathy for a patient who came to me with a very similar presentation. I wouldn't tell them that you have to go up and work and you have to study for this exam. And if you did poorly, you're like a failure of a human being. But I think oftentimes that's how a lot of physicians and trainees speak to themselves, right? They're like, I have to do XYZ in order to deserve to be here, whatever. So yeah, I'm hoping compassion is the way out. I can't deny that sometimes I do revert back to those thoughts where I'm like, if I'm not doing XYZ thing and I'm not like grinding and I'm not like figuring things out all the time, then it's all a waste. It's not worth it. But yeah, I think being able to take that sort of kindness for yourself and be as kind as you would be to a patient is part of it.